Congratulations, Rod and Hootie. You have an all-star cast of people who've lectured here, and Dan Schuba, Mark Bilski, just to name a few true superstars. So just bone graft and tumors, and again, the shadow sides, I have no pertinent conflicts. I am a consultant for Globusar, but I'm not going to discuss their products, and have a number of academic potential conflicts. And I have to disclose a bromance with Dr. Dan Schuber, but since he's left the audience right now, that's less of a relevant disclosure. So as Mark and Rod have identified, there's an increasing incidence of oncologic spine care indications and a potential for much longer survival, which is sometimes unpredictable. And we have obviously a plethora of evolving treatment options, with quality of the life being heavily tied to the integrity of the spinal column. Now, as an orthopedic surgeon, I'd like to just talk about bone healing very briefly. This very much differs by age, location, and patient factors. And it takes place in a realm of hours where the hematoma forms and either consolidates or not, and chemotactic factors, and then a mechanical consolidation. And again, in relationship to the spine, this is something that can take 6 to 12 months. Again, in a child, this is usually something that's under 3 months, but in an adult, this is easily 6 to 12 months. It's actually a board answer. And again, this is a problem in terms of mechanics also. So for instance, the anti-antibody with its far higher mechanical transduction forces will abide by Wolff's laws far faster and consolidate. Like this patient of mine who came back for his 10-year follow-up just in clinic a couple of weeks ago, and was very happy for over 10 years. He has some expected degenerative changes above and below, but he had a very high satisfaction level with a very highly active life. I want to point out that the posterolateral fusion masses, which are well matured in this patient, take much longer to heal and are very difficult to obtain because it's mechanically not an immediate transduction zone, though if we do our job right, it has a healthy muscle jacket. So this posterolateral element is a really great example of a hostile environment for bone healing. Now, there are 3 basic types of bone healing, or shall we say consolidation. One is a complete fusion, one is a so-called stable non-union, the other one is an unstable non-union plus minus infection. So an unstable non-union, as seen here, is something where there's hardware loosening, there's breakage, displacement, pain, neurology, and it will be progressive if left untreated, such as this attempt to achieve a peak fusion, which is basically failed at every single level. The fact that this material is biolucent does not really help us assess fusion or not. In this case, it's simply a progressive loss of any form of fixation, and the hardware will subsequently subside. Much more difficult is the kind of entity of a so-called stable non-union. These patients usually have some persistent pain and aching. There may be some implant settling, which we all accept. And you do need advanced imaging to try to identify what's going on. This is a case of a 52-year-old police officer who had this index surgery, a routine surgery seemingly in 2015, never really got better. Persisted in her work, and was basically just so unhappy. And we could, on close imaging, see that actually hardware had broken. The cages had subsided. These are titanium devices. And again, we can just infer that this never really fully united. It's not really that unstable on flexion extension films, but the patient basically had a hot bone scan. And from that, we inferred that she had a non-union, and due to adjacent segment disease and radiculopathies, we then did a revision surgery with allograft pieces, so a form of biologic material. Now, a fusion in an oncologic patient, as Rod identified, is a really big problem. This is a 72-year-old female with a chordoma, a highly unstable fracture dislocation of C1 on C2 due to this oncologic disease process, which turned out to be a chordoma, just in terms of Dr. Bilski's lecture, a great follow-up, and severe neck pain. Now, in her, there was no option. We had to do surgery. So we did a posterior fixation first, and then the second stage surgery shortly thereafter, an anterior fibula allograft that we hooked into C1 and tamped into C2. In anticipation of needing to have radiation access with SBRT, so stereotactic body radiation, we basically avoided putting any form of anterior hardware into it to give our radiation oncologists maximum angular access, multi-axial access for radiation. And she had one of those miracle recoveries. She was very happy with this. This is her 6-month follow-up, and she's had CyberKnife, so so very high dose radiation into this area, similar to what Dr. Bilski just said, in 3 sessions, fractionated. And she basically has normal swallowing function now. She has a little bit of stiff neck and is actually very happy with this. If you look very closely, the fibula is fully integrated. So we waited with this radiation for about 2 months and then did the radiation therapy. And this is one of the questions that we'd obviously love to ask Dr. Bilski. A newer concept is this kind of an intermediary gray zone concept of what I call metallusion or a peak abusion or something like that. Basically, we have a lot of biomaterials in there, and it may or may not be congealed. We're not totally sure. It's clearly not a full fusion, but the hardware and some of the biomaterials like glass or ceramics create such an artifact environment that maybe something has congealed, but we're not totally sure about it. What we still lack is a true inside the spacers look, whether it's, again, a titanium, a PEEK, or a carbon graphite material, doesn't really matter. We can't really see inside. So osteoblast propagation is something that's very difficult, and osteoclast invasion is something we don't want. And although a lot of these biomaterials now have a titanium surface that is blasted and that endures this more or less osteoblast attachment, this is still very unpredictable de facto. So one is a stable incorporation. If we have a biomembrane with osteoclasts or macrophages in it, this is a stable non-union, or it becomes an unstable non-union. Now let's confront what we have here with a reality check of oncologic cases. So in oncologic spine surgery, we want to maximize quality of life. We want to facilitate tumor care. And the reality is, again, that through many of the modalities present, radiation, chemotherapy, immunotherapy, nutrition, surgical resection, site and technique, embolization, and poor bone stock, we create a wasteland. And again, many of our patients are truly quite sick these days. So the hope to kind of plant something in the middle of a desert is a real stretch and can be quite challenging. So this is where my bromance comes into play. This is a great article that I really quote a lot from 2018 from Dan Schuba and a group of people in the New England area. And they did a very nice predictive study on 176 patients. The goal of the study was, again, to look at a variety of predictive scores to predict tumor management. But what struck me about this was the very careful and curated nature of these patients, of these 176 tumor patients who were followed over a 10-year stretch. And so we see that most of these patients are older with comorbidities. We see that pain is a very common phenomenon that's substantial. 3/4 of the patients had spine fractures, and neurology was involved in about 2/3 of these patients, sometimes even for up to about 2 weeks. We also saw that 2/3 of these patients was mainly bed or chair-bound by the time they found their way to spine surgeons, and 78% had a delayed diagnosis of a month. So why am I presenting these? So first of all, from a surgical tactical standpoint, a substantial majority of these patients required more than 3 levels of surgery, similar to what we showed in the lab before. A number of these patients required some form of a vertebroplasty. And again, 2/3 required corpectomies. And again, 2/3 of the patients had a thoracic lesion. So as we're thinking about what we want to do and what we need to achieve, these are the goals. These are the things we need to try to fight. Now, there's a very big deal in terms of the survival rate. And this is what I'm going to end this kind of a focus on Dr. Schuba and his group's article with. There are clearly good actors shown in the purple kind of paragraphs with well over several year follow-ups that did reasonably well. And then there are patients seen on the right-hand side in this green column who have very poor prognoses, such as, for instance, a Merkel cell, squamous cell, or bladder cancer patients who literally were in the 2-day category. Now, are these absolute numbers? No. But in their prognostic modeling, there's a clear difference between patients who have a more good prognosis side, shown in the green on the left, and a more poor prognosis seen on the right side. Again, these are shifting goals. This is all changing with immunotherapy, but in principle, in a big picture analysis, these are the things that we kind of want to keep in mind as we're looking at a patient's survival chance. And again, when we look and if we use scoring systems, the Tokuhashi score and the so-called SORG scale are probably the best things that we can use. So under and over 1 year is basically, and these are very recent data points, the general gestalt parameters that we can kind of look at. And the other inference in this article is that we do need to think about how we restore the anterior column so that we can somehow help these patients maintain a reasonable alignment, and with that, the goal of a functionally relevant spine. So here we have a number of options. We have so-called cages, we have bone graft, and of course, the subject of autograft always comes up, such as ribs or iliac crest. Now, there's a very simple answer on this. While they heal very well for a tumor disease, we don't need to have a parachute trial. This is simply not okay. Occult disease for us is very clear. And the name Bill Enneking was mentioned by Dr. Bilski in his superb lecture. Autograft is simply not an option in oncologic patients because we immediately defile any one of his principles of disease containment. Another clear no is bone morphogenic protein. Again, this is a very complex protein that induces a lot of immunologic and complex genetic activations. It works beautifully as a bone healing substance in an oncologic setting, although it does not create cancer care. There's an article of ours where we did a long-term follow-up on oncologic patients without spine tumors where BMP was used. There is no relevance in terms of BMP creating cancer. Nonetheless, the immunologic components and genetic interactions with BMP make it unwise to use this in a tumor patient with active tumor disease, as it might unmask unwanted epigenetic side effects. So don't use BMP in spine oncology patients for fusions. Which brings us to allograft, either structural or morselized. And again, structural allograft has been something I've been fascinated with for a long time. It has a lot of advantages. It's highly adaptable and has no donor site morbidity. And industry has fortunately kind of developed a very good kind of a sourcing and tracking system now, so that cost and disease transmission and unreliable organ donor sources have no longer been relevant. But we're still not fully understanding of the true biological responses of these. It's basically an avital graft, and it actually does not fully incorporate into the body. We now understand that about 2 centimeters at each end or the sides, if they're in contact with the cancellous host bone, can incorporate and then remodel, which is a neovascularization. So we actually see active necrosis in these little bubbles on the edges. So this is a phenomenon that kind of is scary, but at the same time, these grafts usually, once they incorporate like this, hold up. You see on the sagittal reformer, for instance, multiple scalloping effects from neovascularization. In trauma, this is something that, again, heals very, very well. And again, the time to union has been well established in several papers. I'm quoting a Canadian paper here, but it usually takes about 36 weeks, so about 3 months for an allograft to heal on, not in. There remain a lot of questions in terms of structural allografts, such as in this tumor patient of mine with sacral reconstruction, which we filled with a allograft morselized donor graft. Whether these actually heal or not is not always totally clear. In this tumor patient, we felt that this was a so-called stable non-union. So despite allograft having some great healing properties and remaining an extremely versatile and essential component for reconstruction, they do heal, but there are a lot of practical issues which make them not so useful frequently. There are some earlier options where we kind of sought to augment them in like tumor patients with allografts and metal composite cages. And again, remodeling has been seen in those. The interface ingrowth can be witnessed. And again, the cages can be placed around it if you need more structural support, such as seen in these cases, that they don't displace secondarily. And again, that can lead to the combination of healing and biology. So allografts are a veritable option, and in our country at least, are readily available in high quality forms and are readily adaptable. And I always want to have one on backup, and I'm very glad to work in a center where we have that. The remodeling patterns are there, but basically you do need to consider that if you have longer reconstructions, they will probably fail in a midpoint. Now, this is what I'm going to lead up with and close with. So we have this era of composite non-fusion reconstructions, and these are very reasonable options. This is a 62-year-old female. She could not sit or stand anymore. She had a loss of bowel and bladder control and breast cancer. Plasmacytoma. And she was actually totally disabled from this. And we did a posterior midline exposure. We did a composite reconstruction with metal cage, structural allograft, quadruple rods, such as identified by Dr. Hart. And again, I have a 5-year follow-up from her, and she's actually independently ambulatory. She wears a diaper for spills, but has a largely intact bowel and bladder function. We were able to preserve her sacral nerve roots on one side. So if we look at this with a CT scan, this is a 5-year follow-up, we can actually see that part of the bone has incorporated, part of the cement has kind of just stayed in place. And it's kind of one of those mishmash things that I'd have to say this is a desirable, stable, non-union. I do not see any osteolysis or tumor recurrence. There's probably a small lysosome around of the PMA when I looked at it with a very careful fine-tooth comb. So, but in principle, this is a very happy patient with a very good reconstruction result after a very complex and challenging reconstruction. She's a very grateful patient. And again, stable fixation was the main thing. So fusion and oncologic surgery are elusive. I think we should really try our best to estimate what is the patient's gestalt. If they live for more than a year or two, we should try to probably induce some form of a fusion. Otherwise, I'm going to stay with Dr. Bernhard Meyer from Munich and basically stay with a stable construct that is biofriendly, hopefully allows for radiation and allows for the patient to rapidly mobilize. If there's a failure in the longer run, we can then revisit how to reinvigorate that and hopefully usually probably get away with a structural allograft if need be. The key is that we have a very efficient and a good soft tissue management, both in terms of exposure and then later a very stable reconstruction. With this, time's up. Thank you for your attention.
That was terrific, Jens. So do you favor, so like on that construct, obviously you use a lot of metal. Do you think that each case is unique?
Of course. I mean, we have to have precision medicine, and sadly, we have still no all comprehensive calculator for what this patient is going to be able to do. I do use a variety of scores. I use a SIN score that Dr. Mendel presented before to help me kind of get a gestalt of the stability or instability. And I try to use either a Karnofsky kind of a score for the viability of the patient, or nowadays, more recently, I've used the SORG kind of an analytical tool to kind of help me understand where is the patient's survival chance. The bad acting tumors will probably just go for damage control surgery. The more benign acting tumors, and I don't want to use the word benign too lightheartedly, here's still a cancer, do probably favor a more lasting approach, meaning a 4-rod construct, for instance, if need be, more biomaterial in there to try to get some healing.
And then I remember you guys wrote a very nice paper with Joe Deditori, I think on BMP.
That's what I just quoted, yeah.
Yeah. You know, I do know, I mean, there's always a chance. Have you used it recently?
Never. I use BMP in non-oncologic patients, but I would never use it in an oncologic patient because, again, we just don't know.
Yeah.
But our paper actually is the longest follow-up and the largest number of patients. And we simply saw no oncologic or oncogenic effect in BMP patients.
So you tend to use allograft.
Very much, and I try to get a structured allograft in somewhere. And again, I saw Dr. Bird, for instance, before showed a very nice allograft reconstruction case. So I try to get a structured allograft, and if healing is necessary.
And how about DDM? Do you use DDM as well?
Yes, I mean, I'll use probably a demineralized bone matrix of some sorts, not ceramic or glass or anything like that.